Good evening and welcome to IHW Council's special web series on reproductive health. I am Kamal Narayan, your host for this exclusive show, supported by Bharat Serums and vaccines under its public health awareness initiatives. The COVID pandemic has put the spotlight squarely on our health. The arrival of vaccine and the start of inoculation process has brought hope to millions who are trying to return to pre-corona days safely. Yet there are many others who find themselves in despair as some of their dreams has suffered a setback because of the many restrictions of the lockdown and the fear of COVID-19. And I'm talking especially about those couple who dreamed about starting a family but are unable to do so because of infertility. And many of them during this pandemic face challenges in accessing or continuing their IVF processes, which has emerged as one of the most dependable way for such couples to get the bliss of parenthood. Infertility over the years has emerged as one of the most common health issues that many young couples have been facing. According to Indian Society of Assisted Reproduction, infertility currently affects 10 to 14% of the Indian population, where scenario is worst in our cities, where 1 out of 6 couple is impacted. On our show today, we will talk about infertility and how you can get on with your journey to beat this. There may be many questions in your mind on what you should be doing to succeed in starting your family. You can ask all your questions right here on this platform. And to answer your questions today, we have one of India's finest IVF expert, Dr. Brigadier R.K. Sharma. He is the Director, HOD, Institute of Reproductive Medicine and IVF Center, Primus Super Specialty Hospital in Chanakyapuri, New Delhi. Dr. Sharma is a renowned IVF and infertility specialist with more than 15,000 IVF cycles under his belt. He was the first to pioneer IVF in India in the public health sector and in the army. He was instrumental in setting up an IVF center in the army. Dr. Sharma set up Assisted Reproductive Technology Center at the Command Hospital AFMC Pune. He also helped set up ART Center at Army Hospital in Delhi. So today we will be discussing about failed IVF and what to do next, and many other questions which we have received from our audience and also which we will be getting from our live audience today. So welcome Dr. Sharma on this special show. And
good evening, everybody.
And thank you so much for sparing your time from your busy schedule. So Dr. Sharma, as I said that this show is going to be all about IVF and how people can beat the this ever-growing problem of infertility. So before we go into the more specific question, I would request you to kind of let us know that how big infertility is a problem for Indian population now, and how IVF has become an important intervention to tackle this.
See, infertility is a problem which is growing over the years. I remember in 1975 when I joined the medical college, out of 200 gynae patients, only one used to be having infertility problem. Others would be coming for prolapsed uterus, fibroid uterus, or other gynae complications. So 1 out of 200 were having a problem of infertility. And when I retired from FMC Pune in 2012, I saw the data that out of 100, 49 patients were from the infertility group. And there was not a single case of uterine prolapse, which we could teach the students. And over the years, the incidence has increased, the awareness has increased, and thirdly, because of change in the social structure, adoption in the family is no more there. So with the result, more and more couples have started coming for treatment of infertility. Earlier, if somebody was not having a child, he would take it from his brother or a sister. But now, because of the nuclear families, that is not possible. So with the result, the patients are coming more frequently for treatment. And secondly, the other contributing factor which I feel is the late marriages, the genital tract infections, out of that tuberculosis and sexually transmitted diseases, which are there because of the uh, extramarital sex and all which patients are having. So they're getting infections and transmitting to each other. So these are the factors, which are causing more and more chances of infertility. Another reason is that if we see our grandmothers, we find that they used to have, onset of menses, what we call menarche, at the age of 16 or 17. And they would get married by age of 18, and by age of 19, they would get one child. And now the girls are getting their menarche, when they're 9 years old. And they're getting married, say, earliest by 25 years of age, especially in the cities. So the best of the eggs which are produced by the body, they just go waste from 9 years to 25 years. So another important factor which we see today is that the girls are having little lesser ovarian reserve, when they really need it. So that is another factor. Then, they are going into the professions, they are delaying their marriages, they're delaying even after marriage, 4, 5 years, they're delaying their first childbirth. And meanwhile, the husbands, if you find that because of the pollution, because of the stress, because of the lifestyle, their semen quality also is decreasing over the years. But since the male produce semen sperms in millions per ejaculate, so you will not see the effect of pollution and other things as much in the male as in the woman who produces only one egg per month. So with the result, the incidence, the awareness, and non-availability of adoption in the family is making more and more patients coming for infertility treatment.
You are saying, doctor, there are multiple factors, and many
Yes.
of the factors are beyond kind of the control of a patient or a individual, right from environmental to social changes to economic conditions, which are contributing to this increasing burden of infertility, and which you are saying from one case into 200 to 49 cases per 100 is the kind of increase you witnessed, which is massive.
Yeah.
So we have also started getting questions, and you mentioned about one important aspect, that the infections and multiple type of infections, be it the STD related infections or other more common infections like urinary tract infections, and those things are also contributing towards kind of complications of infertility. So there is a question from one of the user that is urinary tract infection really dangerous, or let's say it creates more risk for IVF, those couples who are undergoing IVF process as well?
Yeah. See now, when we are talking about urinary tract infection, female can have it urinary tract infection, or the male can have urinary tract infection. Now, as far as the female is concerned, it is quite common to have a urinary tract infection in the females because their urethra, the pipe which is passing the urine from the urinary bladder, it is much smaller in size, and also because the proximity to the vagina and to the anus is there, so with the result they get more incidence of urinary tract infection. And secondly, also because of I would say non-awareness of having a foreplay before intercourse. So their vagina would be dry, and if the intercourse is done the dry vagina, the chances of having microscopic injury to the urethra is much more. So with the result, there's a colonization of the bacteria into those areas, and the bacteria then they travel upwards and cause urinary tract infection in the woman. So the first thing I want to bring is it is more common in the woman, and then it can have a bearing on the continuation of the pregnancy also, because the same woman is more prone for abortion, she is more prone for preterm labors and all. And secondly, because the genital tract is also nearby, the same infection may go into that and obstruct the tubes. Especially the gonococcal infection is there, or chlamydial infection is there, that can cause. In the males, the urinary tract infection is not as common as in the women because of the nature of the genital system which is there. The length of the urethra is much more, and the meatus, the urinary opening, is much away from the anal canal. So, with the result, they get less chances of getting infection. But if because of their habits they get an infection, normally I have seen it is a multiple bacteria's infection. In women, you will find there's only E. coli or a Klebsiella like that, while a male would get 3 to 4 type of bacteria together. And you treat one, you do the culture, you will say first time you may get E. coli, and you treat that, and afterwards you do the urine test again, or you do the semen test again, you find there's a pus cells, and you do again, you find that the infection is now Klebsiella. And in the male, there's another thing which is in between, which is called prostate. Now, the prostate is a gland which is getting the maximum part of her semen. So this gland is, less vascular, and the structure is fibromuscular. And what we call it, the gland is, racemose. Racemose, I mean to say in simple English, it has got small gullies-like system, like Chandni Chowk gullies, or Dharavi gullies, one gully going inside. So these bacteria, they hide in those small, glandular areas away, and the blood doesn't reach. The police is not able to reach there. So with the result, you treat one type of bacteria, and after some time, you find there's another type of bacteria which is coming out. So
That
once a patient male is having infection, we must keep on doing it. After having treated his urinary tract infection, we should do the semen test, and if we find there is a pus cells, then we should treat it in a fashion so that we eradicate the bacteria. Otherwise, the same bacteria may travel one day, and you'll find it may damage their kidneys, and they may land up with the kidney failure later on.
Yeah, so that means urinary tract infection, whether it's among women or men, both is kind of poses a risk for the overall health as well as the the pregnancy and the maybe continuing IVF processes as well. Dr. Sharma, IVF, as I mentioned in my remark also, that has become a kind of one of the most dependable way of tackling infertility among couples and ensuring that they have their baby. But is it kind of so one of the question which we have got is that there is a patient or the person asking that she had 2 failed IVF and she is 45-year-old, and is it possible for her to conceive at this age via IVF? So is IVF kind of a ramban or a kind of thing for all ages, or you have a limitations in that?
See, the first thing which I want to tell is whenever a patient of infertility comes, we should try to find out what is the cause of infertility. Sometimes even simple counseling may be helping the patient because they don't know, how to make a baby. Understood. Or the timings are different. The husband is having different time, the wife is having different time, and they don't have time for each other. So basically, counseling is a very, very important part of investigation and management of infertility. And having said that, the woman age is another important factor. A woman, produces best of her eggs before the age of 35. So after the age of 35, not only the number of eggs is reduced, even the quality of the eggs and the chances of having chromosomal defects in the eggs and also in the embryo is more. So with the result, either the pregnancy rate is reduced or the abortion rate is increased in these patients. So it all depends upon the patient's history taking, the proper examination of what I see. Any patient, the patient is just young and just 1 year old married life. They've hardly stayed with each other. and we say, okay, you do the IVF. No, that is not the way. We must investigate, and there may be a little minor problem only. And I have seen many times in Indian scenario, genital tuberculosis is very, very common, and you may not get the exact picture by just by one investigation. You have to go into the depth, because many of the investigations may come normal. The tubes are open, she's menstruating all right, husband's sperm count is okay, she's got a good number of eggs, and despite that, there are some what do you call that, circumstantial evidences of tuberculosis. And many times we have started the TB medicines based upon our experience and our circumstantial evidences. And the patients have conceived spontaneously also with that, despite trying earlier for 4 to 5 years. So I think proper counseling and proper selection of the patients and proper selection of the management of the patient would do more benefit to the patient than rather than jumping to the IVF directly.
So, but in this case, when you have such failed IVF, instances, and the patient is saying that twice she had failed IVF. So, in that case, is it advisable not to pursue it further because
What's
the
her age? What is her age?
45 years?
Yeah, 45 years. I'm sure her ovarian reserve must have been very, very poor. And with her own eggs, definitely she should not go ahead. If she wants to have baby, if all the other factors are normal, she should go for egg donation. And I'm sure with egg donation, the possibility will be quite high, 60 to 70% chance. Even with that, it is never 100%. But with egg donation, she can try, but not with her own egg.
I think that should solve their or address their question. Dr. Sharma, there is another question, a little specific question, that a patient is having bleeding after 10 days of embryo transfer. Is it normal, or you would like to advise them to seek medical help?
No, bleeding after the embryo transfer, you're asking?
Yes.
Yeah. So now, when it has happened, is it immediately after the embryo transfer, or is it
10
after,
days.
say,
10 days after that.
yes? Now the thing is, how much is the bleeding? That is another question. Was she given any medicines, to build up her endometrium during the IVF? Because if her endometrium was not, of proper thickness, she might have been given proguanovat or estrogen tablets to build up the endometrium. Now, if the patient forgets to take the medicine, the patient can have withdrawal bleeding after stopping the medicine. So sometimes, the patient forgets to take the estrogen support, which should be continued. So that could be the one reason of having a bleeding after 10 days of embryo transfer. And but that bleeding would be slightly higher in amount, lesser than a menstruation. The second thing is, some patients may have little spotting only. Now that can be due to implantation bleeding, and one can do the progesterone test in these patients. And if the progesterone levels are low, then one may step up the progesterone in these patients. Otherwise, how many embryos have been transferred? Now, if the number of embryo transferred are more, then the patients can have a spotting or something like that. During the mid cycle of the implantation period. Another factor is there that some of the patients may have some erosion on the cervix, which is a raw. The cervix is a opening of the uterus into the vagina, which may be raw, or there may be a small polyp over there. In simple English, a wart, what you call it. Now, this polyp, may be very vascular, and patient may have a bleeding not from the uterus. It may be from the cervix erosion or from the polyp. So doctor who would have done the embryo transfer would have kept it in the record, and normally would tell the patient that if you have bleeding, don't get worried. It may not be from the uterus. It may be from the polyp or from the erosion. And in case it is minimal, then you don't worry. Only thing is, if she's been given blood thinners along with that, like ecosprin or LMWH injection, low molecular weight heparin injection, so that should be stopped. And then we also add on one tablet, that is tranexamic acid, to stop the bleeding, so that the pregnancy can continue.
So we advise that I think there are multiple factors, clinical aspects which need to be considered. So the patient should definitely seek help from the doctor, or maybe he can seek help from you also if the patient is in Delhi. So. Dr. Sharma, we are since we are talking and the focus of today's discussion is that failed IVF and what is the way forward, and how people can kind of tackle that also. So there is a question that after embryo transplant, the patient has suffered miscarriage after 6 weeks, and despite the patient being on complete bed rest and maybe other aspects. So what can be the possible reason, and uh, what should be the way forward? Does it shows that IVF may not be the suitable option, or the person should again go for IVF and kind of ensure that the risks or the other factors which might have led to that situation is not recurring?
See, the question is very simple that you said the patient had a abortion at 6 weeks of
Yeah.
pregnancy and she was continuing with the bed rest. So firstly, I want to tell you, patient does not require a bed rest, for long period. She should be moving around after, say, a weeks of 1 week of embryo transfer maximum. Maximum 1 week, that also is not required. Even
Mm,
1 or 2 days of rest is sufficient. Nowadays we are doing the blastocyst transfers, and also within 3 days the embryo would implant, and
mm,
the patient should be moving around because that improves the circulation in the pelvis. It improves better chances of having a implantation, and the chances of urinary tract infection and all are decreased. So we would not advocate the patient to lie down for such a long period.
mm.
So that is not indicated. Now the second thing is having early abortion. What are the reasons, and how do we tackle that? The one of the reasons could be a chlamydial infection. So most of us, we give anti-chlamydial medicines during our stimulation protocol, both to the husband and to the wife, so that because that is also a cause of early abortion in patients. So all the patients who are on IVF protocol during the stimulation, one would get either azithromycin or a doxycycline capsule during stimulation, both the husband and wife. Because if we treat only the wife, the husband may transmit that infection later on, and that can cause an abortion. Having said that, early abortions are also due to chromosome anomalies. So that is aneuploidies and all. The human race is a very poor as far as fertility is concerned. The 70% of the human embryos, even in a natural scenario, are having chromosomal anomalies. So there was a
70%.
study, 70%. So only 30% of the embryos, even in a young couple who are trying naturally, they did a study where they took 25-year-old boy and a 20-year-old girl and 100 of such couples together, and they were given all the free, resting place and food and everything. And after 1 month of copulation, they found that only seven had become pregnant out of 100. The 100 were trying, and all of them were, otherwise medically fit
Mhm.
to have reproduction. And then they said, how it can be so low, the fertility rate. So then they further investigated. They found that out of that, only another 23 had implanted, but they, just bled 1 or 2 days after the expected menses. The patient just thought, her period is slightly delayed, and she was pregnant, but she had slightly delayed 1 or 2 days menses. But then they realized again, the further study was done that actually all 100 had fertilization, but 70 did not implant because of a chromosomal anomaly. Uterus is a very, very intelligent organ. We should not take it just like that it is a vessel where you put a baby and it's all right. Like if I put a embryo of any embryologist who's working in this field, if you show him a buffalo blastocyst, you show a mice blastocyst and a human blastocyst, he will not be able to differentiate. But if you put all the three in different women, you'll find that the buffalo embryo or the mice embryo will not grow into the human uterus. While only the human embryo, whether it is of a negro, whether it is of a European, whether it's of Indian, the uterus would know, yes, this is the human embryo. So that means, firstly, I want to say the uterus is able to differentiate, yes, this is chromosomally 23 pair chromosome human embryo. So I should accept it. And this is a other animal, other species, I should not accept it.
So,
Secondly, the uterus is very intelligent organ to know, yes, this is a chromosomally normal baby who is going to be living healthily. It will accept that baby only. If there is a chromosomal defect, which is a high degree chromosomal defect, the uterus will reject it. It will not allow it to grow. It will not even allow it to implant. So that is why the even if there is a minor defect, the embryo may grow up to 5 weeks, 6 weeks, and then the heartbeat may come, and then afterwards you find suddenly the heartbeat is gone. And if you do the chromosomal study of this product of conceptions, you may find there are some chromosomal defects. So that is another thing. So there are many factors why the patient can have a early abortion, from chlamydial infection to chromosomal defects. And lastly, also, if it is happening recurrently, the patient may have the rejection problem where anti-lupus antibodies are present in the blood, so which reject. So like if somebody's thumb is cut, you immediately suture the same person's thumb over there. The body knows this is my own thumb and it will accept it. But if you cut some other human being's thumb and put it there, the body knows it is a foreign thumb. So it will not allow it to grow. The baby is a half foreign. That means half from the mother, half from the father. So genetically half foreign. So uterus is the only organ which is able to allow the foreign protein or the foreign genes to grow. You can't put a kidney of one person to another person and not give any immunosuppressant. While here the uterus allows, the mother allows her system, immunological system allows this foreign body to grow inside her and nourish into that. But if that system fails, then it may be rejected at 6 weeks or 7 weeks.
so as you are talking about, sir, that recurrent miscarriages, whether after the embryo transplant and otherwise also maybe because of multiple reason. We have another patient whose question has come. It's 30-year-old woman, and she's saying that she had 3 miscarriages in the past 4 years, and each time it was a naturally conceived baby. So should she go for IVF or IUI kind of procedure, because naturally the embryo is not kind of staying, or what is the way
How
forward?
many miscarriages she had?
3 in 4 years.
3 in 4 years.
Yeah.
Now, the first thing is we should know whether they have a consanguineous marriage or not, especially in the Muslim communities and even in the South, in the Hindu community also. They marry in the family only. So that could be the cause of recurrent abortions because of the genetic defects. So, firstly, that should be excluded, that they are not having a consanguineous marriage. So, under that circumstances, even if you do IUI or IVF, she'll conceive and she'll abort again. So under that situation, either they may have to take an egg from a donor or sperm from a donor, depending upon their financial situation and their desire. So another reason for recurrent abortion after the consanguineous marriage, as I said, the body starts rejecting because the immunological system, which is otherwise suppressed, is active in these patients. So these patients, once they conceive, they may require blood thinners, they may require the low molecular weight heparin, and also they may require a more progesterone support to continue the pregnancy. So that we have to see what is the cause. We have to investigate this lady to find out. We have to do the karyotyping of the both partner, even if it is a non-consanguineous marriage, because sometimes there are some chromosomal defects like translocations and all. So the babies, only 25% of the babies are normal and 75% are abnormal. So you must have heard some stories, the lady aborted 10 times and then 11 times, she conceived and she continued with the pregnancy because it is just, game of dice like. So now the chromosome was normal, so she continued.
This too can be considered as a natural phenomena.
Well, it is a natural phenomena, but also it can be, managed. It's not that it's not manageable. So they should do the karyotyping and they should also do the anti-lupus antibody test. And if you find there is abnormality, that can be managed accordingly.
I think so. The patient should definitely seek these interventions and these investigations before taking the further course of action. Dr. Sharma, there are another question that a question has come that a patient has both fallopian tubes are blocked. So, what are the possibility of kind of conceiving naturally?
No, the thing is, once the tubes are blocked, there is no chance of conception. But how it has been diagnosed, that is most important. Because if only HSG has been done, which is an X-ray, in which we push the dye inside the uterus and take an X-ray whether the tube is open or not. Well, that is not a final word, because if the patient had pain during the procedure, there may be spasm in the cornwall end of the fallopian tube. One may get a false information that the tubes are blocked. Actually, the tube is not blocked. Under that circumstances, one should do the laparoscopy to confirm yes, the tube is blocked or not. If the tubes are blocked, confirmed by HSC as well as by laparoscopy, yes, then she cannot conceive spontaneously. But before the treatment of IVF, we should try to find out what is the cause of her blockage, because it doesn't blocks by itself. It has to be something which is causing the blockage. The commonest cause is again infection, and in India the commonest infection is tuberculosis. So we have to see and treat whatever infection she has got, and then only we should go for IVF. Otherwise, if we don't treat that, you'll find we'll fail again, because the infection will not allow the pregnancy to occur even in the uterus also, because it is still lurking around there. And whenever the tube is blocked, it can be blocked, at the attachment to the uterus, or it may be blocked at the other terminal end. And then there is a fluid collection. We call it a hydrosalpinx. There is a water inside the fallopian tube. Now, this, if that be the case, so not only we should treat the infection or the disease which is causing it, we should also do the delinking of the fallopian tube. Otherwise, that dirty water keeps on coming into the uterine cavity, and it makes it hostile for the implantation. So IVF would fail. So where is the block? What is the cause of the block? Treat that, and then only do IVF. Naturally, it may not be possible if there is a true block there.
Sir, in general, what are the chances of IVF getting failed, and how to avoid that?
Okay. Now the thing is, it all depends upon what is the age of the woman, age of the husband, what is the sperm count, what is the quality of the sperm count, DNA fragmentation, because that is happening now because the lifestyle, smoking, drinking, not sleeping in time, the DNA fragmentation in the sperms are increasing. So with the result, the pregnancy rate decreases and abortion rate increases because of the male factor. Similarly, in the woman, how many ovarian reserves she has got, and what is her age. Because of the age, the number as well as the chances of aneuploidy is increased, so chances of success is reduced. Having said that, if the patient is having adequate number of eggs, 10 to 12 eggs during stimulation, and if the count is okay, and she forms 70% embryos out of that, we will call it, yes, she is an ideal case for success. Now, under those circumstances, the success rate when you do the blastocyst transfer, it is never more than 60%. As I told in the beginning, only because many of the embryos, they may look morphologically normal, but yet they may have a chromosomal anomalies. As I told you, 70% of the human embryos are having abnormalities. So we tend to transfer not one embryo, we tend to transfer two embryos at least in our Indian conditions, where the patient is paying from her own pocket. In foreign countries, they do single embryo transfer because they are possibly the insurance is paying it. So there, they can afford to have a failure or a lesser success rate. But in India, the patient is paying, the patient doesn't mind twins also. Because there the NHS has to pay for the twins also, their management in the neonatology and all. So there, by law, they are putting only one embryo. Here we may have to put two or maybe three if there's a recurrent failure also, not more than that. So the success is never 100%, That should be told to the patient in the beginning also. And the reasons are either there could be chromosomal anomaly in the embryo. Now, even if we test the chromosomal anomaly of the baby, there is something called mosaicism. Now, there is a technique, PGD, what we call it, where we can, PGS, where we take one or two cells from the embryo and do the chromosomal test, whether the embryo is normal or not. Now, even that is not 100% because there is something called mosaicism. Some cells may be normal, some cells may be abnormal. So what we have tested is a normal cell, by other cells which were supposed to make a baby were all healthy and we have discarded the embryo, and vice versa. So that is not very important investigations, and it just add to the cost of the treatment. Unless yes, there is a family history of some chromosomal anomalies and all, there it will help the patient in selecting the embryos of a normal chromosomal structure. So even if we have tested and we have put the normal chromosomally normal embryos, then also the success rate doesn't grow more than say 65% or so, for the various reasons. Because the whole of the uterus, is not conducive for implantation. There are some areas of the uterus which are more conducive. There are electron microscopic changes which are happening. We call it pinopods, which are forming. So if the embryos, they are able to reach the pinopods, even if we put the embryos in the uterus, they don't stay there only. They roam around in the uterine cavity. Try to find out where is the best place. And, that is again a matter of chance that they reach the right place and the uterus accepts it. And afterwards, it doesn't reject it. So there are so many important molecules which
Factors
are
are
required.
associated with that.
And nowadays, another thing, what we were earlier not, understood, which we are now understanding, there can be infection inside the uterus, which may not manifest clinically, but it is a cause of implantation failure. So again, every day the new, insights are coming, which are increasing. See, every year we are having not more than 1% increase in the pregnancy rate over the years, despite all the latest investigations and the interventions and all. So
So Dr.
before becoming
Sharma,
100% will take time.
the 60% of those people who go for IVF, there are chances of only 60% getting successful. So
Yeah,
what about those rest 40%? What is the way forward for them? Is there
yeah,
any other solution available for them?
yeah. Now, thing is, the person who is failed, it is very difficult for the doctor as well as for the patient. And we have to understand that what is the cause of failure, we must know, because then only we can improve on the next time. I always say IVF is not only therapeutic, it is diagnostic also. Because when we take out the egg, we see it under the microscope. We realize, yes, this is a good egg, this is a bad egg, which we couldn't have seen it otherwise. A very young patient, perfectly all right, healthy patient, and we take out the eggs, and repeatedly we find there are vacuoles in that, there are granules in that, there are abnormal eggs. Genetically, they are abnormal eggs. So definitely, if next time I have to advise her after that failure, I would tell her that she may go for a egg donation rather than. So that means I have got a information of the previous IVF, what was the quality of the egg, what was the quality of the sperms, and how many embryos had formed out of that. Whether my lab was able to have 70% embryos in that particular patient, while all other were having 70%. So if it was say 10%, 20% embryo in this particular patient, while the same day or the same week, other patients had 70%, that means there's something wrong with the sperm or the egg. I should, be making records of that by the looks of it. Okay, the sperms had this problem, the vacuoles in their head, or the eggs had the problem, and the shape of the egg, the zona, how was it, and other morphological features and all, the quality of the embryos which was there, and then the embryo transfer, how difficult it was or easy it was. So all these things are noted. So next time when we do it, we try to improve on that. so that the chances of success would increase. So the first failure will not only be waste, it will be teaching also, that okay, this is the cause which you can correct it next time. And then, because all the things cannot be known beforehand, unless you take out the egg and see it under the microscope, you cannot know. So similarly, unless you see the sperm fusing with the egg and forming a baby, you will not know the fertilizing potential of the sperms. Sometimes the sperm count is perfectly all right, egg is all right, and the sperm is not able to fertilize the egg, even if we do the ICSI in them, because it is not able to stimulate some processes in the egg which are required for a baby formation. So there is some inherent defect in that egg.
So,
So
Dr. Sharma, what I'm kind of understanding from your talk, that there are multiple factors and a lot of investigations has to be done, and a lot of diligences need to go when you are kind of going ahead with IVF, or the doctor who is kind of doing that IVF. And if there is a failure, there has to be learning out of it, which can lead to a more kind of successful IVF
the next cycle, yeah.
procedure. But is it that kind of diligent process followed by all the doctors, or it is some doctor follow that, some don't follow that? Is there a
No,
protocol for that, do you need to go about it like this?
the thing is, any doctor worth his salt would be doing that, I'm sure. It is not that, because no doctor who's practicing would like to see failures, isn't it? So I'm sure all the doctors who are doing it, the experience may differ. That is a different thing. With the time and all, you learn more and you understand the things more. That is a different thing. But definitely, I'm sure I have got all faith on my young doctors and other colleagues and all. They do their best under the circumstances, whatever, wherever they're working. And the only thing is that the patient should also understand that it is never 100%, and should have patience, should discuss with the patient what could be the cause, and the doctor should be able to explain this could be the cause. It may not be the 100%, but they may be at least may be able to understand 40%, 50% of the causes, and then which are manageable. Another thing which we do routinely after failure, we take before the patient gets the menses, we take a small endometrial biopsy and do histopathological examination in that, because there is, I always say, there is a triangle of activity which is going on inside the uterus between the endometrium, embryo, and the progesterones which we are giving. So all these three are interacting with each other, and that can be seen by doing the biopsy whether that interaction was complete or not. Many times, despite having good embryos, you have given adequate amount of progesterone, and when you do the biopsy, you find that the changes which the progesterone was supposed to produce in the uterine cavity, secretory changes have not happened. So the baby was not, the embryo was not able to get the food which is required for it to grow over there. That wouldn't have been known unless we had done that biopsy at that time. Like, the question may arise in the patient's mind, and why didn't you do the biopsy earlier? Yes, earlier we had done it during a laparoscopy if it was done, or histoscopy, but that time we had not put the embryo. Embryo is also one of the key players in bringing about some changes in the decidua or in the uterine cavity. It is also, it is not just only a parasite on the mother. It is directing some activities in the uterine cavity. Okay, mom, I have come inside. Now, mom, please give me milk, give me that. It keeps on telling the uterine cavity, bring out these changes. And then the uterine cavity, the decidual changes happen. So there have been studies, where they have seen with the embryo and without embryo, the differences were there. So what I mean to say is that after the failure, we should do a biopsy of the endometrial cavity and see. You may find some surprises. Like I told you, you may not find the changes which are supposed to happen. You may find there is a inflammatory, they say inflammatory cells present inside the uterine cavity which are not supposed to be there. So that means some infection was there, which was the cause of non-implantation or failure of this thing. Now this infection might have come with the sperm, with the semen, with the embryo. or during the technique of embryo transfer. Anyway, it can, reach inside the uterine cavity, or it was already there previously, which was cause of the failure. And sometimes you find that, yes, now we find a plasma cells over there, or maybe some granular tuberculosis, which was, we had done all the tests earlier, we didn't find anything. But now, because we had given high estrogen, the patients were estrogens were very high, progesterones were very high, the uterine wall had enough time to grow, and now you find that there are plasma cells which are present, and you do the PCR for tuberculosis, you find earlier it was negative, now it has come positive. So there are a lot of information which can be collected after the failure during the process of IVF, which can benefit the patient in the future, cycles.
So I think what you are trying to highlight, doctor, that failure is not the end of the road. There is a new learning from it, and then definitely can contribute to more successful outcome from IVF or any other assisted reproductive technologies. Uh, we also advise our patients that they should keep faith on this the technology. They should talk to the doctor. They should try to find out the causes which are kind of leading to the failure, and then try to manage them.
That should not be a, one thing I want to bring it, at the clinic level also. So it should not be a blame game between the embryologist and the clinician, and it should not be a blame game between the clinician and the patient. They all must sit together and see, because it is a science,
Yeah.
isn't it? I many times, when the patient asks me, sir, what is the cause of failure? Though I had already discussed everything beforehand, what could be the cause of failures and all before we start the IVF, this is success rate and this could be cause. I always say there are two ways of explaining the failure. One is a simpler way and one is the longest way. Simpler way is that we create human bodies, we can't put a soul into that. The soul comes from top only. And unless the soul comes into that embryo, it cannot grow. There is a simplest answer which I can give you. The longest, I told you that science is there. I will tell you the thousands reasons why a patient cannot conceive, and each pregnancy is a miracle of God.
Yes, yes. So that I think message should everyone should have with them. Since you were talking about multiple tests, doctor, so there is a question which is unanswered yet. That is rubella IG test required for IVF treatment?
So it is required, as a screening procedure. Rubella is one infection which normally happens before a girl attains puberty, and there is IgG will be positive for her life. That is a good thing. Okay. Now suppose if I have to do IVF, I should do a rubella test.
Kind of highlighted that what all procedures and aspects need to be taken care of by the clinician side of also. What is your message for these couples who are kind of living with infertility, or those also who are planning to kind of conceive and are not successful in their efforts? So how should they go about it? And also those who are seeking IVF procedures, are undergoing IVF procedures, what they should keep in mind, how they should modify their lifestyle, and what are the risk factors which they can avoid kind of getting into this process.
See, firstly, the couple, even if you go to the market to buy a small piece of cloth, we always want to see at two, three shops and see which is the best cloth and where we get a better choice. We should not go only by the, newspaper ads, and we should not go by the, advertisements and all. We should do the study ourselves. We should, because nowadays ample information is available on the Google, so one should know. And secondly, the two things which I always would advise the patient: they should select a center which has got a dedicated IVF specialist as well as a dedicated embryologist. It's not that the embryologist is coming from some other place and doing it and then going away and then coming. That is not the way IVF should be done. It should be a regular, clinic where they are doing IVF every day, and with the result, they know where is the problem. Troubleshooting is much better, and they can give better results. And that is one thing. The selection of is the prerogative of the patient, and they should know, okay, what all I have to see if I have to select which doctor to take the treatment from. This is what I would say. And secondly, they should try to discuss with the doctor what is the cause of their infertility, what should be done to improve on the success rate, and then only go for the IVF. Not that, okay, this is the month I want to do the IVF and not, I cannot wait like that. Because some patients may require 2, 3 months of preparation before doing IVF because of the disease which they have it. Secondly, after having discussed the protocols, having discussed the problem with the doctor, and after the doctor is investigated and all, once they start the treatment, the few things is there that they should take adequate rest, because if they are sleeping less, the secretion of melatonin, which is being produced in the night, will be less, which is a natural antioxidant, and which is also improves chances of success in the patients. So they should sleep adequately. Secondly, they should avoid alcohol and smoking before actually. And if the couple is overweight, they should try to reduce the weight, change the lifestyle, and do adequate exercise, walking more, maintain their weight first. And then, depending upon the ovarian reserve and all, whether we want to do early IVF or little, we can delay for some time because of these, extraneous factors. One can decide upon that. And during the IVF program, there are some injections given at different timings and all. They should learn from the doctor or from the center how to take the injection, how to keep the injections, because cold chain is very important. So they should know that they have to carry the injections in a ice pack, keep it in the chiller tray, and while taking out, they should not keep it outside for a long time before taking it. So all this nitty gritty they should understand, and then they should even if they have some questions, there should be a mechanism from the clinic. At odd hours also, somebody should be able to answer. If not the senior doctor, the junior doctor should be able to answer the queries, because many times the patients may realize, oh, I have got this powder and water. How much powder to be mixed to give the injections, which may have a bearing on the result later on. The timings also, should be ensured that this is the time I have to take the injection, so timings are ensured. After the embryo transfer also, there are some do's and don'ts which we tell the patient they should follow those do's and don'ts, and they should be physically as well as mentally at rest, because if they are stressed, so then the chances of success would be definitely lesser if they are relaxed. So the patients, if the patient, there are different personalities. So if they require, any counseling for that, they should get it done beforehand only, so that they are not stressed up during the treatment. And the whole family should be actually sort of educated wherever possible, to keep the conducive environment for the pregnancy to happen. And
Yes.
there are other about the Indians are very, very Ayurveda has taught us many things, like the seeds of papaya, they can cause uterine contractions. So seeds of anar can cause. So normally we advise, okay, you avoid papaya, you avoid pomegranate and pineapple, and avoid non-veg also, because nowadays, to give boost to the muscle mass, injections are given to the animals. So then a lot of toxins are present in the fish, mercury and the lead, especially the rivers are polluted. So we advise them to avoid the non-veg and take more of vegetarian food. I have got some other, reasons for that, which I can discuss later on if somebody wants to know why non-veg should be avoided.
Thank you so much, Dr. Sharma, for kind of guiding these couples and those patients who are undergoing IVF treatment, or overall trying to manage or coping up with this problem which is emerging in fertility. Uh, I'm sure those who would like to kind of know more would be contacting, and they can contact Dr. Sharma at the Primus Hospital. Definitely seek appointment and can meet them. Dr. Sharma, thank you so much for your time today to answer many of these questions. So for my audience, here was Dr. Brigadier R.K. Sharma answering your questions on infertility and its management and cure. The project start from BSVL, of which this program was part of, aims at providing support to couples beyond medicine and initiatives like microfinancing the treatment and counseling. Project Start also encourages couples to stay on course for IVF treatment to achieve their goal of parenthood. Uh, if you have more questions, you can send them to us through WhatsApp. To use you can click on the WhatsApp button on our page. Also, don't forget to follow us to stay updated on all that concerns your health and well-being. We will be back with our another special show on reproductive health next week. And so keep sending your questions, and we will be certainly including them in our next show. And as we are still not out of the pandemic, do take care, a very good care of yourself, and keep following the COVID appropriate behavior of wearing mask, and sanitize your hands regularly, and follow social distancing. And also, as Dr. Sarma has also highlighted, eat healthy, sleep well, and keep giving your mind and soul a daily dose of positive thinking. Goodbye, and see you all soon.
Thank you.
Take care of friends.
Thank you so much, Dr. Sarma. Hope you liked the program. It is, I think it has been more.